Time now for this week's Health Matters with PA Lynn Szabo. And I understand we have some good news.
Good news, and the hot off the press good news.
Oh, boy.
In the time of Omicron. So,
What's your good news? What do you got?
it's going to be hard to pronounce, but let's give it a go.
Okay.
So, brand new from AstraZeneca is the new monoclonal antibody Evusheld. Do you got a better idea?
Evusheld? Yeah, that seems like about right.
Evusheld?
Sure.
Yeah. So what's cool about this is it's a monoclonal antibody, and it's a combination of two monoclonal antibodies, and I'm not even going to try
come
and say them. Oh, my God, it's horrible. Tixagevmab, something like that. I won't even try the other one. But here's where it's really cool. This is super cool. This is used for pre-exposure protection against COVID.
Wow.
Or as we say, pre-exposure prophylaxis. Okay? And it's for people specifically with moderate to severe immunocompromise that blunts the response to the vaccine, or people who legitimately cannot be vaccinated for some reason.
I'll be darned.
I know. And used on adults and kids over 12 years, and the kids have to be over 40 kilograms, which is about 85 pounds. So recent emergency use authorization from the FDA. Okay.
Okay, so how do we use this then? If it's just
So it's 2 shots, 150 milligrams of each of the monoclonal antibodies, or given IV, and it's given every 6 months. So if you can't get immunized, or if you're on a medication that blunts your response, like an immunomodulator, and that's pretty common up here, like people with rheumatoid arthritis or psoriatic arthritis, then this is something they can use. The vaccine is much preferred, but if you're not getting, as much out of the vaccine as, your doctor thinks you could, then you could go ahead and use this in addition, or if you're allergic to the vaccine solely.
wow.
What are you going to say there, Mike?
I was gonna ask, how would the doctor know whether or not? I mean, if people are getting the vaccine, how would the doctor know whether or not they're getting the appropriate amount?
It's a judgment call, because I don't think you could measure antibodies, or if you did measure antibodies, and let's say most people have like between 50 and 100 level. If you had like 12, I've seen 12, as low as 12 2 weeks after vaccination, then that person might be a candidate. But I think it's going to be based mostly on a little bit of educated guesswork by the provider and a long look at the med list.
So the antibody testing that's available now, does that just tell you presence of antibodies? It doesn't give you any sort of level?
So that's a good question. So what's available now just says positive or negative.
Gotcha. Yeah.
The machine reports out a numeric value, and you have to know the lab guy to get it. It's not officially.
Okay.
So, for example, I've seen antibody reports all the way from 12. This is 2 weeks after second shot to 400.
Wow.
And so the 12 was a woman who was pretty healthy. She's in her 50s, but she has a history of cancer, not being treated currently, considered cured. And then the 400 was my daughter's boyfriend, who's just, healthy 20-something. So you get 2 shots. They want it to be IV is ideal, but intramuscular is acceptable. This is cool. No dose changes if somebody has liver or kidney disease. So that's really good. But some caution for use if people have bleeding disorders. So I looked into that a little more deeply, and that's only because you're giving somebody a shot.
Oh, really? That's it? That's the only...
It's kind of like in the initial vaccination question list, they asked you if you were taking aspirin. They just want to be able to counsel you to put pressure on the site so you don't get a bruise.
Okay. So this could apply to any shot.
Right.
Okay, gotcha.
It seems like a bit of overkill, but yeah.
Yeah. Well, they're kind of good at that sometimes. So no data available for pregnant or breastfeeding women, but the American College of Obstetricians and Gynecologists is working on a position paper right now.
Do you anticipate anything with that? Because that's been a big stick with the vaccinations, just people being reticent about the vaccinations because of questions.
I think it's a relative risk question, and I think a pregnant woman in the time of COVID has way more risk to her health and her baby's health from COVID.
Right.
Than from any vaccine or monoclonal antibodies.
Mm-hmm.
So it sounds like, and I think you already said this, that your healthcare provider will likely, based on whatever your chart says and the medications you've been taking, would then use that to assess whether or not the vaccines might have a lower impact and then prescribe this instead.
Yeah. So there is going to be I wouldn't call it guesswork, a super educated guesswork, but there's also going to be kind of a timing thing here. And there's going to be some consideration with that. And the cool thing is, and I'm kind of foreshadowing, is that we're getting told to study up on it right now. And the meds are expected to be here in late December, which is already passed.
So what are you saying? You're anticipating that this will become a big treatment then that'll be used?
Uh-huh.
Okay.
Yeah. So adverse reactions are minimal. So 1 to 10% fatigue, headache, and then one site referenced cough, but the other sites did not. Less than 1% allergic reaction. So that's good. So 99% of people do fine with it. There's some question in people who have risk for cardiovascular disease. In the studies, it looked like they had kind of worsening of their cardiovascular disease after they got the shot, but it's unclear whether it's related. You would certainly have an increased risk of cardiovascular disease from getting COVID. So again, relative risk. So cool stuff about it. This is made with 2 different monoclonal antibodies, which are protective in 2 different ways. So this is something that was kind of learned from HIV. If you give drugs that attack the virus in different ways, the virus has a harder time finding a go-around.
Mm-hmm. Yeah, sure, that makes sense.
And then it's likely to be protective against Omicron because each component works differently against the virus. However, it was tested mostly against Delta. Okay. It's not a treatment. That's what's really important. And I don't even think some of the providers have gotten that realization. This is not something you go behind the hospital and get monoclonal antibody treatment when you're sick. This is an alternative to vaccination for people who are immunocompromised.
Okay.
Would people who have already been exposed to COVID, would this be contraindicated for them?
No, they're actually talking about that, but the data are not in yet. So that cool thing, that's called post-exposure prophylaxis, and they're looking at this as actually a way of post-exposure prophylaxis for people who are at risk. So they're still recommending, however, vaccine being the best way to shut the virus down. Super cool stuff, and I've kind of alluded to this. So providers at UHS and Del Norte Community Health Center are already being trained for the use of these medications because Del Norte will be getting free doses of Paxlovid. Remember that was a treatment we talked about? Molnupiravir. I'm not sure I said that right, but so we're going to, what I envision happening, although I'm not the decision maker on this, is if you drove up and you got COVID tested and it was positive, there would be a provider intervention that could actually hand you the meds.
Wow.
So not going to the pharmacy, not worried about who pays for it, that we're actually going to get the meds and be able to hand it to you. And I think that this particular monoclonal antibody prevention is also going to be available, although it's unclear whether that'll be in clinic. But it's going to be for people who meet criteria. So this is some super seriously good news.
So I'm trying to figure out where this fits in. Then we've got antiviral medications that are coming online. We have vaccinations that are available. So does this kind of, I guess it doesn't bridge the two, but it's much closer to the workings of a vaccination, of a vaccine, than it is
to preventative. It's kind of like if you can draw if you can look at HIV, you know that there is pre-exposure prophylaxis available for HIV, and some people, take that daily or episodically. This is kind of the same thing.
Wow.
Yeah.
Huh.
Yeah, I didn't see this coming, but it's so elegant, I think, and I'm super excited about it.
And it seems like with COVID, like they're plugging all the holes therapeutically. Like they're coming at it from a lot of different ways.
Right. So once you understand the life cycle of the virus, then this is stuff we drew from HIV, hepatitis C. Then you can start poking holes in it on a number of different levels.
Yeah.
And then be more effective both in treatment and prevention.
Wow.
Yeah, this is super cool. Now, I wonder, this is something that immediately occurs to me is, with people who have HIV, they get a viral load done. And that's kind of really elegant, simple way of knowing how active their virus is inside their body. I wonder why they don't do that with this. Maybe because in 10 or 14 days, most people are done. Or maybe...
That would be it. It's not as chronic. It's not as an ongoing
but maybe
status.
Maybe they're actually doing that in an intensive care unit because that could control treatment.
Right.
You could also really quickly find a response to treatment so that you could stay a step ahead.
Is that
super cool?
Go ahead. No, is that sort of analysis, viral load, is that something that's widely available to places like, like Sutter Coast?
I don't know that it's available. I think it's probably available at the tertiary care level, but although I wouldn't be surprised if it was at secondary, like St. Joe's Providence.
Okay.
But I think if Sutter had it, I'm not sure the turnaround time would be meaningful enough that you could use it.
Right.
But if somebody was flown out to Medford, I wouldn't be surprised if they were really sick in the intensive care unit, that technology wouldn't be used for them.
So one of the things that I've heard is different reports on the efficacy of the vaccines when it comes to affecting transmissibility of COVID.
Right.
Will Evusheld have any effect when it comes to the transmissibility of?
I don't think those data are known yet. I'm not even sure they would be looking at it right now.
I'm just wondering, do they act in similar ways? Because it sounds like it's a different thing.
No, it's a different thing. So,
yeah, but they would look. It's a different aspect of what you'd look at. I mean, they're looking at. They're not dealing with the R naught.
Right.
That's not the concern with them. It's like stopping it right there with this treatment.
So it's for people who can't respond. So think about it. When one gets vaccinated, then one develops the individual's own antibodies. This is kind of a giving people antibodies ahead of time. So it takes kind of a step out of it. And there is a hypothetical thought that if somebody were immunized, they had a poor response, that if they had these monoclonal antibodies, that would decrease the efficacy of their vaccine. But this is where I think the timing is going to come in. And I think if one got vaccinated and then maybe 3 months later not due or not clear that they would need a third jab or a fourth jab, probably be a fourth jab, then this is something else they could do and still be protected, because there's a ton of people out there who are immunocompromised and not quite ready for their fourth jab, but are a little worried reading the news. So this is something that could be used to kind of keep protecting somebody until they could get to, it's like going stone to stone across a creek, I think.
So the vaccine, of course, helps your body create its own antibodies. Will Evusheld do that at all?
I don't think so. It's not meant to do that.
Okay.
Yeah, it's providing the antibodies for you.
Yeah, I'm just curious because, so it's just putting them there, and then you would have no response. They would just be there.
I mean, if I'm understanding it correctly, it's basically like if you had been vaccinated but without being vaccinated, right? I mean, you're just going in and around the vaccination route.
It's a little bit like using a different monoclonal antibody. There's a lot of monoclonal antibody preparations that are used to treat acute COVID. This is just one that's used for pre-exposure, pre-illness.
Yeah, I guess where I'm trying to get to is once those antibodies, maybe this doesn't happen, but once the antibodies from Evusheld have gone their natural course, you would then have no antibodies, correct?
Right.
Yeah, you could look at it like that.
That's why you have to come back 6 months later.
This is going to be like a 6 month.
Okay, it's going to be a recurring thing. It won't be a one and
for a period of time until COVID's not a thing anymore. I can't believe I'm saying that. That's not going to happen.
You're asking for it.
Yeah. And, the interesting thing, too, is that it doesn't seem like the body is stimulated to produce antibodies against the injected monoclonal antibodies. So it doesn't seem like it provokes an allergic reaction to itself, which is super cool.
Yeah.
Yeah.
So, okay, let's get political. So the fact that will COVID lead to universal health care? Just because in the face of an emergency, we're waiving all the costs.
The sun coming up should lead to universal.
There you well,
Is
okay,
that really
true.
Questionable?
That's your pie in the sky answer. But here on planet Earth,
Right.
where America exists, it seems like we're just waiving all the costs because it's an emergency. We've got to deal with this. So that just kind of, do we need to pay all those costs? I mean, it sort of leads, the follow along logic says, okay, well then if we can do this and provide all this free medicine for COVID, why not for other things? So
I think that's a fine question, and obviously I think it should happen.
Yeah.
And
I'm just wondering if this is like the point of the wedge, where maybe we're...
I hope. I super hope so.
Yeah.
And this is probably expensive, but I don't think that it's more so than other things that we spend money on at the federal level.
Sure.
And actually, I think it could save money in the long run because a shot of this, I have no idea how much it costs. Okay, but let's say it's $10,000. That's still cheaper than an ICU.
Right.
That's multi-million dollars of care. So. You could look at this as actually money saving.
Any timeline? I mean, you said the Del Norte would be getting.
They said we were going to get it at the end of December.
Wow,
that's happened.
Okay.
But I haven't really been in clinic since to actually see it. But word went out to all the UHS providers that we have to bone up on this particular kind of medicine.
Wow.
Can I ask a political question?
Sure.
What do you think about the changing of the guidelines that came out of the CDC related to quarantine times and all of that? Because to me, it seems like, I read that Delta Airlines had communicated and saying, oh my God, we can't have people out for 10 days. Right. And then that sort of spurred some of this. And I've heard people like Dr. Fauci and others, if not admit it, say, oh, well, we have to balance society being able to continue running, which means people going back to work.
Two thoughts on that. One is that I thought it was super interesting. The announcement was made without any reference list of data that they based the decision on. So I think it was a political decision. And number two, it's already happening in Del Norte. Almost every hotel or restaurant has their own guidelines that they use internally that have nothing to do with any kind of scientific reality. And I have seen workers get sick because their coworkers were forced to come to work when they were positive. So that's, people are kind of already doing it, and I think the government's following, but I don't think it's justifiable from a public health standpoint.
Yeah, and I guess for me, it just seems like it has the potential, the very good potential, to just further erode trust in organizations like the NIH and the CDC and all of that. But
I also think that they might have an opportunity here with Omicron because it's thought to be less severe a disease, that they could, I don't know that they could get to herd immunity, but they could get closer to, Xanadu and get an idea, kind of nudge the population along, especially the ones that won't get vaccinated. Because if they're refusing vaccination, their inevitability is they're going to get sick with this.
Will anybody who refuses to get vaccinated be eligible for something like Evusheld? Or will that be something that will be very strictly...
Yes, but many of the arguments against the vaccine could apply to this. I guess you could say it's still experimental because it's only got emergency approval, which is a significant thing. I shouldn't have said only. That's a significant thing. And so I think if people are honest and have intellectual honesty, if they have that objection to the vaccine, they'll have that objection to this. But yeah, this is a really good thing, and it's elegant and it's going to help. And if you as an individual are wondering if you are in the category of moderate to severe immunodeficiency, that was written a little vague, then you should talk to your provider about the possibility of doing this. It will be available in Del Norte.
Wow. At some point too, I think we should have some sort of a segment show just about how modern medicine has really hit it. I mean, nobody's talking a lot about this, and we're all arguing about it all. But modern medicine's just really hit it out the park with COVID-19 and the coronavirus.
Oh yeah, and I'd be interested in kind of looking at the ties to what we've learned slowly and painfully with HIV, hepatitis C, and hepatitis B, and how
that decades-long struggle, right?
How those discoveries were like super helpful.
Yeah,
there.
yeah.
And some of the really simple things, simple, elegant medicine, just beautiful, stunningly beautiful.
Yeah, we should set aside some time to celebrate, in this era of where we're shooting ourselves in the foot and arguing about, and I feel like we can't accomplish anything as a society anymore, and all of the stuff that personally and culturally it seems we need to point out the fact that, look, science is doing this. Science is doing exactly what science is supposed to be doing and saving lives, and we're busy arguing about all this other stuff.
Yeah.
I heard an interesting report on BBC. They were talking about mRNA vaccines and people objecting to them, going, "Oh, well, they're new." And somebody said, "Well, just because they're new to you doesn't mean that they're new to everyone."
You're right.
Yeah,
exactly.
That there's been a lot of work going on.
That's a super good way.
Yeah, well, I thought it was very straightforward.
Yeah. Wow. Well, Lynn, anything else?
No, just happy news.
And Happy New Year.
Yeah. Oh, yeah. I might say one tiny political thing. So there's a little bit going around.
I thought you was going to say, "Let's go, Brandon."
No, that would have been wild, wouldn't it?
Oh, God, no.
So I'm sorry, I interrupted. Yes.
There's stuff going around on the internet that says the CDC has admitted that the COVID testing is wrong and this is actually the flu.
I've seen that. Yeah.
That would not be true.
Yes. Yeah. Just
that is all.
If you had any questions about that.
One of the myriad of things that would not be true.
Would not be true. Yeah, that's a bad idea for a show. All the things that aren't true. Let's do that. Well, Lynn, thank you very, 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 very much. And it's good to see you and not over the phone as we were.
I know, this is funner.
This is, Sure. Were you able to enjoy your quarantine at all?
Not really.
Not really, yeah. Yeah, we know
boring.
What kind of person Lynn Szabo, PA, is. She's got to be out there in the trenches.
Doing the thing.
All right. Well, thank you, and we'll see. Any idea about next week?
No, but I have this feeling something amazing is going to happen, and we'll see.
Wow. Okay.
Maybe we can get our own Evusheld drip.
Lynn, thank you very much. Health matters. We'll talk to you next week.
All righty. Bye-bye.